Welcome to the deep dive. Today, we're really getting into a specific, but wow, really impactful area in veterinary medicine, peripheral nerve sheath tumors.
That's right. Specifically looking at schwannomas in dogs and cats.
And the sources we're drawing from today, these are essentially clinical guides, right? The kind of stuff veterinary specialists would use.
Exactly. Very detailed, sometimes pretty dense material.
So, our mission here is to kind of unpack all that, pull out the key takeaways for you.
We want to understand what these tumors are, the signs they cause, which, really depends on where they pop up.
Yeah, and how they're diagnosed, the treatment options, the challenges there.
And ultimately what the outlook might be for these pets. Basically, a shortcut to getting up to speed on this specific topic.
Okay, let's jump right in then. What exactly is a schwannoma?
So at its core, a schwannoma is a tumor that comes from Schwann cells.
Schwann cells. Those are the ones making the protective layer around nerves.
Precisely. The myelin sheath for peripheral nerves. They're literally tumors of that protective layer.
And they fit into a bigger group called peripheral nerve sheath tumors, or PNSTs.
Correct. That's the broader category.
Now, the sources mention something that sounds a bit confusing. They're often called histologically benign, but also locally aggressive. What does that actually mean?
Yeah, that's a really crucial point. Histologically benign means when you look at the individual cells under a microscope, they might not look overtly cancerous. They might seem, relatively well-behaved individually.
Okay, so the cells themselves don't look super angry?
Right. But, and this is the key thing, their behavior where they grow is aggressive. They're highly infiltrative.
Meaning they grow into things.
Exactly. They invade and grow along the nerve, pushing into and damaging the healthy nerve tissue and anything nearby. They don't tend to metastasize or spread far away like many malignant cancers, but their local growth is the major problem.
So even if the cells look okay, the tumor itself acts aggressively right where it is, invading the nerve.
Precisely. And that aggressive local behavior is why, clinically, they're often grouped with other tough soft tissue sarcomas like fibrosarcomas. Treatment planning, prognosis, it follows similar lines because local control is just so difficult.
Got it. And how does that differ from the malignant peripheral nerve sheath tumors, the MPNSTs?
So MPNSTs share that nasty local infiltration. They're also hard to remove completely.
Okay.
The big clinical difference is that MPNSTs can metastasize. They can spread maybe to lymph nodes or even the lungs.
So that adds another layer of danger, the potential for spread.
Exactly. That significantly worsens the prognosis, obviously.
So both types are difficult locally, but the malignant ones can travel. And because even the benign ones are invading nerves, what are the consequences? Why are they such a big deal?
Well, because nerves are involved, the impact is huge. Nerves control movement, sensation, pain signals. When a tumor infiltrates or just squashes a nerve,
It messes up the signals.
completely. It leads to serious neurological problems, often really intense chronic pain, that neuropathic type of pain, and you see significant muscle wasting, atrophy, in the areas that nerve supplies.
Which leads us right into the next point from the sources. Where these tumors grow is absolutely critical.
It's going to be more important. Since they come from nerves, they can theoretically appear anywhere you find a peripheral nerve.
Which is pretty much everywhere outside the brain and spinal cord itself.
Basically, yes. Cranial nerves, spinal nerve roots coming off the cord, nerves in the limbs, under the skin.
And the specific location dictates the problem.
Absolutely. It determines which function gets disrupted.
Yeah.
Is it limb? Is it chewing? Breathing? Sensation? It all depends on the nerve involved.
How exactly do they damage the nerve? You said infiltrate and compress.
Yeah, the tumor grows either within the nerve's protective sheath or wrapped really tightly around it. As it gets bigger, it physically squeezes the delicate nerve fibers, the axons inside, and it infiltrates between them, disrupting their structure. This breaks the communication line, causing loss of function and often triggering those awful pain signals from the damaged nerve itself.
Okay, what are some of the really common or particularly problematic spots the sources mention?
Well, there are a few key areas vets worry about. Tumors on the spinal nerve roots, especially if they grow into the spinal canal.
Pushing on the spinal cord itself?
Exactly. That's very dangerous. Can affect multiple limbs, bladder, bowel function. Very serious.
Okay, what else?
The brachial plexus, that big network of nerves controlling the front leg, that's another really common and notoriously difficult location.
Yeah, I've heard those are particularly bad news.
They really are. Other important sites include the trigeminal nerve that affects chewing muscles and facial sensation. big problems with eating.
Right.
Laryngeal nerves affecting the voice box, causing breathing difficulties. And then you have the ones closer to the surface, under the skin, cutaneous or subcutaneous nerves.
So they can be hidden deep inside or be a lump you can actually feel. Did the sources mention any others? Vagus nerve.
Yep, the vagus nerve is possible. They also touched on some historical classifications, like certain heart-based tumors sometimes being linked, though that's viewed differently now as chemodectomas.
Okay.
But the main point is, nerve origin means diverse locations, and that diversity directly causes the huge range of signs we see.
Okay, let's talk about those signs. Given the location variability, are there any general red flags? Common themes?
Yes, the sources definitely highlight some common threads. Pain is almost always a big one.
Just general pain.
Often it's that specific, severe neuropathic pain. Owners might describe it as like a burning or shooting pain. It can be hard to pin down exactly where it's coming from initially.
Okay, pain is a key feature. What else?
The signs are usually progressive. Some overnight thing like, say, an injury.
Gradual worsening. Makes sense.
And because the nerve isn't working right, you almost invariably see muscle atrophy. The muscles that nerve control start to waste away, they shrink.
Progressive pain, muscle wasting. Got it. Now let's get specific. What about those spinal nerve tumors? What signs would you see?
For spinal ones, the signs show up in the limbs behind where the tumor is. So lameness, weakness, what we call paresis, or even total paralysis, plegia.
Okay.
They might be wobbly, uncoordinated. That's ataxia. They might not know where their feet are, proprioceptive deficits. Touching the spine near the tumor is often painful spinal hyperesthesia.
And you mentioned something called root signature.
Yes, that's a classic sign described. It's severe radiating pain, often down the affected limb, that gets much worse with certain movements or even just touching that spot on the spine. It really points to nerve root irritation.
Sounds awful. And bladder bowel issues, too.
In severe cases affecting the lower spinal cord or nerve roots, yes, you can lose control.
Okay. Brachial plexus tumors. What does that look like?
Often starts as a severe lameness in one front leg. Sometimes they won't put any weight on it at all.
Non-weight bearing.
Exactly.
Yeah.
And the muscle wasting in the shoulder and leg can become really dramatic over time. Very noticeable shrinking.
And you mentioned something quite distressing earlier. Self-mutilation.
Tragically, yes.
Mm.
The pain or abnormal sensations, the paresthesias, can be so intense that the animal starts compulsively licking or chewing at the leg.
Wow.
And if the sympathetic nerves in that plexus get involved, you might see Horner syndrome too, droopy eyelid, small pupil, sunken eye appearance on that side.
Okay, trigeminal nerve tumors. Signs relate to its function.
Right, so chewing and face sensation, you see atrophy, that muscle wasting of the big chewing muscles on the head, the temporal and masseter muscles.
So their head shape might change.
It can, quite noticeably. They'll have trouble picking up food, difficulty chewing. Sometimes you can detect a loss of sensation on that side of the face too.
And the laryngeal nerve ones.
Those cause signs of laryngeal paralysis. Noisy breathing, especially when breathing in a harsh sound called inspiratory stridor. Their bark or meow might change. They might tire easily with exercise because they can't get enough air.
And finally, the cutaneous ones under the skin.
Those usually just show up as a firm lump you can feel. It might be painful when you touch it, or it might not. Sometimes the skin over it or around it might feel numb.
Okay, so the signs point you in the right direction, hopefully narrow down the location. But how do you confirm it's actually a schwannoma? What's the diagnostic process?
It always starts with that detailed history from the owner and a really thorough neurological exam. The vet is trying to localize the lesion, figure out precisely where in the nervous system the problem is originating. Assessing the pain, the muscle atrophy pattern, reflexes. It's all part of that puzzle.
Neurological localization. Then you need pictures.
Imaging is absolutely critical, and the sources are unanimous. MRI is the gold standard, especially for anything involving the spine, spinal nerves, or cranial nerves.
Why MRI specifically? What makes it so good for this?
It just gives phenomenal detail of soft tissues, nerves, spinal cord, brain. That's what MRI excels at.
Better than CT.
Much better for this purpose. MRI lets you see the tumor size, its exact relationship to the nerve. Is it inside or outside the dura, that tough membrane around the spinal cord? How much is it compressing or invading the nerve tissue? It's vital information for planning treatment.
And it helps rule out other stuff, too.
Definitely. Things like slip discs, intervertebral disc disease, or IVDD, are super common causes of spinal pain and deficits. MRI is great for differentiating those from a tumor, though the sources do note the MRI appearance of schwannomas can vary quite a bit.
So it's not always a classic look. What about other imaging, CT scans?
CT is good for looking at bone. So if the tumor is suspected of eroding into the vertebrae, for example, CT can show that well. It can see masses, but it just doesn't give that same exquisite detail of the nerve and tumor interface that MRI does.
Ultrasound, X-rays.
Ultrasound can be useful for superficial lumps, cutaneous ones maybe, or sometimes to help guide a needle for a biopsy in the brachial plexus area. But it's limited for deep structures. Regular X-rays, usually not diagnostic for the tumor itself, but might show subtle bone changes if it's been there a long time, or help rule out other causes of lameness, like arthritis.
Any other advanced tests that get mentioned?
Sometimes CSF analysis taking fluid from around the spinal cord. It might show high protein levels if the tumor is irritating the spinal cord or inside the dura. Helps rule out inflammation.
Okay.
And electrodiagnostics, EMG, and nerve conduction velocity studies. EMG measures electrical activity in muscles. NCV measures how fast nerves conduct signals. These can confirm there is nerve damage and help pinpoint which nerves or nerve roots are affected. One source really emphasized that EMG is consistently abnormal in the muscle supplied by the affected nerve.
So imaging gives strong clues. Electrodiagnostics confirm nerve dysfunction. But getting the final answer requires what?
The definitive diagnosis, according to all these sources, requires biopsy. You need tissue.
Taking a piece of the tumor itself.
Exactly. A pathologist needs to look at the tissue architecture under the microscope. That's histopathology. It's the only way to confirm it's a nerve sheath tumor and, crucially, to tell if it's a benign schwannoma or a malignant MPNST.
Is grabbing that biopsy straightforward?
Not always. The sources warn that biopsying a nerve itself carries risks. You could potentially worsen the neurological signs or cause more pain if you're not careful.
Right, delicate structures.
And it's important to know that just sticking a small needle in for a fine needle aspirate, an FNA, that usually doesn't give you enough information. It's generally considered non-diagnostic for these tumors. You need a chunk of tissue.
A core biopsy or an incisional biopsy.
Right. And often they'll use special stains on the biopsy, called immunohistochemistry, to help confirm the cells really did originate from Schwann cells.
It sounds like quite a workup. History, exam, advanced imaging, maybe electrodiagnostics, and then a careful biopsy. And ruling out other possibilities is key too.
Absolutely critical. Especially with spinal signs, you have to rule out things like IVDD, other tumor types, even inflammatory conditions. For limb issues, you think about trauma, other sarcomas, inflammatory nerve disease. The diagnosis needs to be thorough.
Okay, so let's say you've gone through all that, you have the diagnosis. What are the treatment options? What do the sources point to?
The main recommendation, the primary treatment goal, is surgical excision, trying to remove the tumor.
Cutting it out. And the goal is to get all of it.
That's the ideal, yes. Complete removal.
Yeah.
But remember that locally aggressive, infiltrative nature we talked about.
Yeah, right. That makes it hard.
It makes it incredibly difficult to get clean surgical margins, meaning removing every single microscopic tumor cell, even for the histologically benign ones.
Why is it so hard? Because it's wrapped around the nerve?
It's often within the nerve sheath growing along and between the nerve fibers. So to get it all out often means you have to remove the segment of nerve that it's involved with. You have to sacrifice the nerve.
And sacrificing the nerve means permanent loss of whatever that nerve did.
Exactly. Permanent neurological deficits, loss of muscle function, loss of sensation in that area. It's a huge trade-off.
Wow. What happens if they can't get it all? If the surgery leaves some tumor behind?
Then the risk of it growing back, local recurrence, is very high. One source put that recurrence rate as high as 72% if the excision is incomplete and you don't do anything else.
72%. That's huge.
It is. So techniques like laminectomy, removing part of the vertebra, are used to get access to spinal tumors. For tumors way down on a limb, sometimes amputation is the only way to achieve those clean margins, although sometimes limb-sparing surgery is possible.
Okay, surgery is the first line, but it's often incomplete or requires major sacrifice. What else can be done? Radiation.
Yes, radiation therapy is a really important partner to surgery here. It's often recommended after surgery if the margins weren't clean to try and kill off any remaining microscopic tumor cells and reduce that high recurrence risk.
Makes sense. Can it be used on its own?
It can. If surgery isn't an option, maybe the tumor is in a place you just can't safely operate. Radiation can be used as the primary treatment. Often the goal there is palliative.
Meaning not necessarily cure, but control and comfort.
Exactly. Shrink the tumor, slow its growth, and really importantly for these tumors, alleviate that severe neuropathic pain. It can significantly improve quality of life, even if it doesn't eliminate the tumor entirely.
What about chemotherapy? Does that play a role?
Generally, no. The sources consistently state that chemotherapy is considered ineffective for most Schwannomas and PNSTs.
Even the malignant ones?
It might be considered for the aggressive MPNSTs, but the response rate is usually poor. One source flat out said no successful chemo management has really been described for these, so it's not a go-to therapy.
So it really boils down to surgery, often followed by radiation. And you keep mentioning the pain. Managing that must be crucial.
Absolutely fundamental. Pain control is paramount throughout. It needs a multi-pronged, multimodal approach.
Not just one drug.
Unlikely to be enough. You'll often use a combination. Standard NSAIDs might play a role, but drugs specifically for nerve pain are key. The sources specifically mention gabapentin as being helpful.
I've heard of that for nerve pain.
Yeah, it's commonly used. Sometimes you need other drugs too, like amantadine or even opioids for severe pain flares. Physical rehab can also be part of the plan, helping manage muscle stiffness and secondary pain.
And just general supportive care, keeping them comfortable.
Essential, especially if they have significant weakness or paralysis and can't get around easily. Good nursing care is vital, preventing bed sores, keeping them clean, helping with urination or defecation if needed, making sure they're eating and drinking. It's a big commitment.
Okay, so we've covered diagnosis and the challenging treatment landscape. Let's talk outcomes. What's the prognosis? What can people expect?
This is where the sources stress there's huge variability. It really depends.
Depends on what? What are the main factors influencing the outcome?
Several key things. Location is definitely one. Tumors squeezing the spinal cord or tangled in the brachial plexus are just inherently riskier and harder to manage functionally.
Makes sense. What else?
The single most important factor, echoed across the sources, is the completeness of surgical excision. Getting those clean margins is the biggest predictor of success in terms of local control.
Clean margins, best chance. Positive margins, high risk of it coming back.
Exactly. If margins aren't clean, the prognosis is much more guarded without follow-up treatment like radiation. And then, of course, the histological grade, is it benign schwannoma or malignant MPNST? That matters too, especially for the risk of spread.
Can you give some specific examples from the sources, like best case scenario?
Best case, a benign schwannoma may be somewhere accessible, like under the skin, that is completely removed with wide, clean margins confirmed by pathology. The prognosis there is considered excellent, with a low chance of it coming back locally.
And if excision is incomplete for a benign one,
Then it's guarded without radiation. High chance of recurrence.
what about spinal schwannomas after surgery?
For neurological recovery, the prognosis is often rated as good to fair. Many improve. But it's more guarded if the pet had already lost deep pain sensation in their limbs before the surgery. That's a poor prognostic indicator for regaining function.
But pain relief might still be good.
Yes, often pain relief after surgery is significant, which is a major plus for quality of life, even if they don't walk perfectly again.
And those really tough brachial plexus cases.
Yeah, the prognosis for having a normal functional leg after surgery is guarded. Complete removal often necessitates nerve sacrifice, leading to permanent non-weight-bearing lameness.
And the self-mutilation can persist.
It can, unfortunately. That severe pain or weird sensation might continue either to the tumor is out, sometimes leading to the need for amputation down the line.
Yeah.
And again, high recurrence risk if margins aren't clean or radiation isn't used.
And the malignant MPNSTs, generally worse.
Generally, yes. Guarded to poor prognosis overall. They're invasive locally, and they have that potential to metastasize to lymph nodes or lungs. Survival times tend to be shorter, even with aggressive multimodal therapy.
You mentioned an interesting detail about recurrence time varying by location, too.
Yeah, one source cited data showing that for nerve root tumors that had already grown into the spinal canal, the median time before recurrence was quite short, maybe only about a month.
Wow, that's fast.
Compared to brachial plexus or lumbosacral plexus tumors, where the median time to recurrence was longer, around 7.5 months. It just highlights how difficult those intraspinal ones are to truly control long-term.
Finally, before we wrap up, did the sources note any key differences between dogs and cats?
The main thing is prevalence. These tumors are diagnosed much more commonly in dogs than in cats.
But they do happen in cats.
Oh, yes. Location might differ slightly in frequency. Spinal roots and brachial plexus seem very common in dogs. Maybe cranial nerves, like the trigeminal, are relatively more frequent sites in cats compared to limb nerves, but both species can get them in various places.
But the approach to diagnosis and treatment is similar.
Largely, yes.
Yeah.
MRI, biopsy for diagnosis, surgery and radiation as the main treatments. The principles are the same.
And the prognosis factors are the same too. Location, removal, grade.
Correct. Those factors dictate the outcome similarly, regardless of whether it's a dog or a cat.
Well, this has been a really thorough exploration. We started with defining these complex nerve tumors, looked at how their location completely changes the clinical picture.
Yeah, the importance of advanced imaging like MRI, the need for biopsy.
Right, and then the treatment challenges, the difficulty of surgery, the role of radiation, the limited options otherwise.
And how the prognosis can range so dramatically based on those factors we discussed.
This deep dive really aimed to pull together those crucial points from the expert sources, giving you a solid understanding of schwannomas in pets.
Absolutely.
And maybe a final thought for you to consider based on all this. These cases really force some difficult conversations, don't they? You have this potential need to sacrifice nerve function, maybe even a limb, to get the tumor.
Against the high risk of recurrence if you don't,
Oh.
and the constant battle against that severe nerve pain.
It really puts a spotlight on that tough balance veterinarians and owners have to find between pursuing aggressive treatment and focusing on maintaining the best possible quality of life for that individual animal. It's rarely straightforward.